listening to The Doctor's Corner with Dr. Kline and Janelle Elgoway.
Good evening and welcome to The Doctor's Corner with myself, Janelle Elgoway, and Dr. Kline. If you have a question, please call in at 415-915-2291. Tomorrow at 8/7 Central, guest Dr. Edward Spencer will join ConNation to discuss losing his physician's license to treat patients, all because he spoke up publicly about vaccinations. We will also discuss the links and similarities of health epidemics throughout history within the United States. Tonight, we will discuss what CDC data use disorder is and the major problems that it is causing for you and I. Welcome, Dr. Kline. How are you this evening?
I'm just fine, Janelle.
Good. Since I've started advocating, the one thing I've asked myself is why I couldn't find the same numbers when researching statistics in the United States on the topic of opioids. For example, overdoses and deaths. And depending on what source you look at or what media outlet you listen to, it's different. A few examples are the Washington Post states 100 Americans die of drug overdoses each day. The Associated Press states dozens of Americans die daily from overdoses of pain relievers, heroin, and other opioids. And then Fox News states two different things. More than 40 Americans die every day from prescription opioid overdoses, or roughly 78 Americans die every day from overdoses of opioids. And I think that's just interesting how they have two different numbers for the same statistic. Why is it so important that we have the correct information?
It depends on what you're trying to do with the numbers. For example, I heard recently that there's 10 elephants running around in Tennessee. That's more elephants than any other state in the entire country.
Right.
So what would my point be of saying that? Maybe I don't like elephants, or I'm alarmed about elephants, or I think this is a lie. Actually, there are 10 elephants in Tennessee, and they're in a great big preserve that some people put together to help retired circus elephants. And they have this enormous place, and they wander around. So, what would my point be without giving the rest of the story?
Right.
So why would somebody say there's 50 opioid deaths every day? Well, first of all, we got the word opioid, which is a new term in spite of what everybody says. They had to add it to the law, the 1970 law, which set up the DEA. So why pick a word that nobody knows? And then why present these statistics, 50 a day, 100 a day, quadrupled since 1999, more than automobile accidents, leading cause of death under 50. When people start to say things like that, you have to say, what's your agenda? Mm-hmm. If I went around saying there's 10 elephants running around, and people would say, well, so what? So the biggest question of all in science, philosophy, and everyday life is, so what? Now, if you can't make your point, then you're obviously spouting statistics for some other agenda. And we call those agenda statistics. So, for example, the various numbers have to do with the CDC's classification of overdose deaths. But before we get into the details of that, to give you an example, it looks like there's about 50 deaths every day from opiate overdoses, and that's overdoses in heroin addicts, not overdoses in the backyard of suburbia. 5% of overdoses are probably kids, teenagers and stuff who are not on the street, or probably were on the street. But by comparison, so we got 50 a day deaths from opioids. There's 240 deaths a day from falls. Mm-hmm. There's 300 deaths a day from alcohol. Guess how many a day from smoking? 1,300.
Wow.
So there's 1,300 deaths every day from smoking, and there's 50 a day from overdose of opiates. So what's going on is people are trying to make a point, and the point is, hey, you know what? You've got to be afraid of this. The United States is the only nation in the world that's afraid of opioids. And I'm going to start using the term opiates, because opiate, painkiller, is really what we're talking about. The best term, and it would stop all the CDC fiddle-faddling with the numbers, the best word is narcotics. Mm-hmm. CDC presents its numbers like this. Well, there's heroin overdose minus methadone overdose minus fentanyl, because that's a synthetic, and you have to have semi-synthetics, and then there's the synthetic group, and we're going to give them all a number, X41. The truth of the matter is that this is all collected from death certificates. Death certificates are the least, most accurate way to determine what's going on. I know. I have filled out death certificates, and sometimes you don't know what's going on. Mm-hmm. So they call a coroner. Now, where I practiced in Oregon, we all took turns as primary care doctors being the coroner, right? No training, you know. So the coroner arrives on the scene, and there's some person dead with tattoos. What do they say? Must be a drug overdose. And they write up the death certificate, unspecified drug overdose. Now, the good ones will draw blood and get blood samples. So they come back, and the blood sample's got 8 different drugs. So what did the person die from? He's got 8 drugs in his bloodstream. So they don't know either. So what they do, what CDC does, is it counts 8 different deaths for the same person.
Okay.
Chalks up one death for heroin, 1 for alcohol, 1 for cocaine, 1 for oxycodone. And then they take all the oxycodone tallies, and they say, these are prescription drug overdoses. They don't know that.
So it looks like it's 9 different people? It looks like 9 different people died then instead of... Okay.
Yes.
Wow.
Yes. So all the... You see, if you add up all the subcategories, they don't add up to the total. Now, they don't fudge the total. So the total was 33,000 last year of people who died. And that sounds like a lot, and it is a lot. And you can't say, well, gee, that's a small number. But compared to the other things, as I just rattled off, it's down the list in terms of health priority. If there's 1,300 people dying a day from tobacco, and there's 50 a day dying from heroin overdose, which one do you want to focus on?
Right.
See, they don't put it in perspective because the CDC has an agenda. And the agenda is anti-pain and anti-opiate pain medication. That's their agenda. And there are key people in the CDC, not a lot, just a small handful, but they're running a whole division, the division that produced the CDC guidelines, which are not based on fact. As a matter of fact, they said so in the CDC guidelines.
What issues arise from these numbers, like and not having the correct data? What will become of that?
Well, you see, any numbers that are being used for an agenda, it's the agenda. So what's the agenda in North Carolina, where we live? The governor here was in D.C. at opioid summits, conferencing and blah, 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 getting on television. And 3 weeks later, guess what? A grant from the federal government, $25 million, to fight the opioid crisis. Now, I'm not quite sure what they're going to do with the money, and actually I'm going to look into it. Because a lot of times this is just free money, you know. And, of course, they say the same things. Let me just, out of the newspaper here, let me get it. Okay, we need to focus on law enforcement, decrease supply, education, and rehab. Those are the things we need to focus on in this continuing battle against this terrible scourge. Well, this is from the New York Times. in 1951.
Oh, wow. Well, it's the same thing today.
So in 60 years, in 60 years, nothing has changed. You know, if you're doing something for 60 years that doesn't work, you know what? It's not working. They blame the doctors. Back in 1951, Dr. Spear from the New York Medical Society said he's sick and tired of hearing the medical profession blamed for failing to stop the increased use of narcotics.
Mm-hmm.
Does that sound familiar?
Mm-hmm.
Yeah, it's in here, group health insurance not covering treatment for people with addiction.
Well, and I noticed a lot of Kolodny's terms or his one-liners or whatever that he says. It sounds like things from 30 years ago, like from the 90s, or 2000s,
well, or even before that.
Or before that, now, yeah.
Yeah, I mean, these things here in the New York Times in the 1950s, association with addicts is the chief cause of addiction. It just goes on and on. I got all these sheets here, but eventually I'm going to write a little story and sort of draw all these things together. Oh, all the drugs are coming from communist China. Well, now it's just China.
China, all right.
Yeah, we have to educate the students, and the drug czar at the time didn't want students educated because he felt that if you educated kids, they would just run out and get more narcotics.
Right. So I was wanting to dive a little bit deeper into this so we could understand more. You said the CDC did a use disorder. What does that mean? Is this a term that you came up with, or what is that?
Well, it's sort of tongue in cheek.
Mm-hmm.
The government has invented a new term, opioid use disorder, OUD, or the Substance Abuse Federal Agency. That's the name of it, the Substance Abuse and something or other Federal Agency, gets $1 billion a year. They invented the term substance use disorder, SUB. Mm-hmm. These are all terms that supposedly mean addiction disease. But when you look carefully, I mean, these are huge papers. These things are 300 pages long. So you sit there and look through them, and you find out the way they determine somebody has opioid use disorder, which everybody thinks is addiction disease. Mm-hmm. They went around, paid people $35, and went into their house and sat down and asked them this questionnaire. And the question on the questionnaire was, do you ever take your opiate prescriptions in a manner not the doctor ordered? In other words, not on a bottle.
Right.
I don't know. I do, Most everybody does. So if you answer yes to the question, guess what? You're chalked up as a substance abuse disorder. Then they published it in the paper.
Wow.
And now these are increasing. Well, they're increasing because the SAMHSA, SAMHSA, a federal agency in charge of substance abuse, changed the definition. The psychiatric definition for opioid use disorder used to be persistent use without control, and it sounded kind of reasonable for somebody with addiction disease. But now the government is inventing, in order to get more funding, because CDC got increase in their funding this year, as did the substance abuse people. Mm-hmm. The only thing that got increased in the federal budget were things to deal with the opioid crisis. Now, crisis means money. They're going to pump $5 billion in the next fiscal year. $5 billion in the next, to do the same things that I just read you from 1950. We're going to reduce the supply, increase the DEA, and we're going to have educational programs that basically people running around saying don't take drugs. We're going to have treatment facilities, and they'll never pan out. They didn't in 1950 either. They all wanted treatment facilities, but then, I don't know if we have enough money in the budget for that. That sounds kind of expensive. So they never take place. And so it just ends up being a police state because they got all this extra funding. And I'll tell you, there's nothing the police love better than arresting people on drugs. It's easy. You got them on you, and they get an arrest to chalk up.
Do you know if, I know they're trying to pass laws in the states as well that to put a tax on each milligram of an opioid, would that go towards it then too? I mean, why would they need to do that?
Well, this whole mess got started in 1915 when everything was fine and addicted people were being treated by doctors with morphine, which they, by the way, in New York in the 1950s they were trying to do also, which we now call MAT, medication-assisted treatment.
Mm-hmm.
Where was I going with this? I drift off.
Oh no! I was just asking. Why would they tax each milligram per?
Oh, the tax. Yes.
Yeah.
So in 1915, a bunch of radical moralists got together and tried to convince Congress to outlaw all opium products. So that would have been morphine and laudanum and everything they had. Mm-hmm. Well, the Congress didn't really want to go that far, so the opioid fanatics got Congress to pass a tax. So the Harrison Act in 1915, which started this all, mm-hmm. was a tax initiative. So what happened when they taxed the opium products, which, by the way, were sold in drugstores, except for prescription morphine? Mm-hmm. So the price went up. Then they started arresting doctors in 1915 because they were treating addicts. They thought that was immoral. And so then the price really shot up.
Have they ever taxed?
So now,
okay.
Not that I know of, just back
mm-hmm.
to federal tax.
Okay.
So I think the state's so what's going to happen in the state, they're going to make things worse. They're going to drive the price of opium products up. There'll be more deaths on the streets from heroin as it did in 1915.
Wow.
By the way, 1915 is when the heroin epidemic started. It didn't start in 1999.
It didn't.
Or
okay.
Whatever they're claiming.
What created the epidemic then, or what started it? Pricing. At the time, there were 200,000 addicted people. We have 1 million today, about the same balance given the increase in population. It's about 0.5%. And so addiction as we define it is intense seeking without regard to consequence. That's my personal definition. Okay. Mm-hmm. Do you know if when after wars and stuff like that, and vets or soldiers come back, were there ever? Did you know if there's spikes with prescription opioids, or have you ever seen anything with that, or no?
The Dwight Eisenhower formed the first opioid commission, and he declared the first war on drugs. As a matter of fact, he invented the term because he was concerned about the soldiers coming back addicted. Mm-hmm. And what happens is, and I just talked to a Vietnam veteran the other day, he said it was so horrible over there for draftees, being just told to go out in the rice paddies and shoot anything in sight. He said that he thought at least half the soldiers were on heroin, and he said they were all on marijuana.
Right. Wow.
So when they came back, there was the same concern. The Army was concerned, gee whiz, all these people are coming back addicted, are we going to have to pay for it? Mm-hmm. And I think I mentioned before the study that was done in 1974 when I was at Stanford and was sort of part of it, was that of 100 GIs that came back on pure intravenous heroin they had been on for months, only 2 people out of 100 addicted continued with their addiction. So addiction is still rare, but it was a problem with the military, and it was a problem after the Second World War. Mm-hmm. And that's when Eisenhower got into the picture.
Mm-hmm. The CDC admitted recently that the RX opioid deaths were significantly inflated. Do we know how inflated these numbers were?
They had to cut them in half.
Okay. And then it
went from 33.
Go ahead.
33,000, which is the 90 a day, and they had to cut it to 17,000. So that's going to be 45 people a day. So now you see there's a real problem because
right.
they're claiming that the epidemic is increasing in heroin overdose deaths every year. So now that they cut them in half, I don't know how they're going to compare it with previous years.
Right.
I think the CDC needs to appear before Congress and explain themselves.
Mm-hmm.
I mean, when you have statistics that are turning on an entire wildfire of purposely taking away pain medicine from people based on this phony statistics, you need to explain yourself.
Right.
Because they started it. Good.
Well, you know, and I would even take it one step further than that. Before they, you know, change any more laws or put anything else into effect, I think, you know, that the CDC should have to go in and explain themselves, because, you know, there is no alternative stuff right now, it seems. And if they are, a lot like some of the stuff that they do say that you can do instead of taking them, it's not covered by your insurance. So, I mean, they're creating a big problem here that's even so much more bigger than, you know, what they have right now. So it came out also that there was a disclaimer of these 4 researchers for the CDC and that they were writing an opinion piece. What do you think about that? And is that legal for these researchers to be able to write opinion pieces?
It sounds like they're hightailing it out of town to me. One of the 4 researchers was one of the CDC writers. Mm-hmm. There were 3 people that wrote the CDC guideline, and she's one of them. It was published in an obscure journal, and I went to get a copy of it today, and you got to pay $35 just to get a copy of the article.
Wow.
So fortunately, Josh Bloom did pay the $35, and he wrote a nice little piece about the sham that's going on. You know, I mean, they basically cut the estimate in half. Good Lord, what are they doing? These people are hired with fancy salaries, PhDs, that are in the business of epidemiology, collecting data, analyzing data, and here they have to say, oh, gee, we're like half off. We're off by 100%. So why bother? But you see, what it does is it stimulates the $5 billion and expenses that everybody gets in on. Just there's so much money flowing from the opioid crisis fight that who's going to say, oh, gee, you know, let's check the facts on this. Maybe there is no opioid epidemic. And the opioid epidemic, by the way, here's the numbers from 2013 to 2014, the death rate, this is heroin death rates now, not in the general population, went from 9 people per 100,000. The next year it jumped to 10 per 100,000.
Wow.
It increased by 1 person per 100,000. It's not my job to determine whether or not I think that's a big number or a small number. It's really up to everybody who listens to the number. And that's one thing I don't like about the CDC data people. They pass judgment. They use words like astonishing increase, major increase, significant increase. And then they use what I call the Senate statistics. That's my little parable. So you got a Senate that's got 100 members in it, right? And there's 2 members that want to pass a law to require everybody put their cats on leashes. So that's 2% of the Senate. So they round up a couple more people. Now they got 4 people in favor of leashing cats. So it's now gone from 2% to 4% of the Senate is interested in this bill. But you could also say the number of people who are in favor of this law have increased 100%. That's what the CDC does. They take a statistic like it goes from 9 to 10, and they say, 10% increase.
Right.
That's not true.
The CDC also talks about traditional definition and conservative definition. Can you explain the meaning of these 2 terms and how they're used?
They made it up.
Oh, they did? Okay.
Yep, they just made it up in order to explain themselves. Instead of saying it's a corrected number, we did it wrong. Oh, this is a conservative method. That's almost laughable.
I mean, I don't understand how they can do that. If they've messed up, fine, then just come out and say it. But I mean, putting a lie over a lie, or it just makes it so much more confusing. Are there?
Yeah, it's like kids in elementary school.
Right. Right. Is there anybody else that that the government, that whoever will listen to besides the CDC? Why aren't we taking information from other publications for statistics and stuff like that?
Well, it's out there. NIH, National Institutes of Health, which we doctors kind of consider our mothership, did produce some very nice graphs, which anybody can find. It's NIH September 2017 revisions. If you put that in your Google, you can find it. Mm-hmm. It's got some really nice graphs. And one of the graphs, the fourth one, shows the the opiate overdose deaths. No, prescription drug opiate. Prescription drug overdose deaths. And you know what? The graph is flat for 7 years.
So what made it go up?
It's not prescription drugs going up. It's heroin and fentanyl that's going up, and also actually cocaine has gone up as well. But it's not prescription drugs.
Wow.
That's been flat. So that's a fib that you can see with NIH data. That's, get it on your computer. So the CDC is not the agency mandated by law to do anything with prescription drugs. Only the FDA has rule-making authority, they call it. In other words, when all these agencies are set up, the law gives them each something to do. The U.S. Army does not supervise the growing of cotton, because they are not the regulatory agency for that. Mm-hmm. So the CDC, if it wanted to say anything about prescription drugs, needs to go to the FDA first.
If you look back over at history, there's been all these different epidemics that have come up for obesity and other major health issues. And if you look, the statistics that the CDC used were wrong in that too. Why are we still listening to the CDC when they've made so many mistakes time after time throughout history?
Well, it's become a thing of itself. In other words, the CDC was the car, the traveling car that threw a cigarette butt out the window and started a forest fire and then drove off. Mm-hmm. And is not claiming it. Oh, what, me? The problem is if you start a forest fire by accident or on purpose, you're still culpable either way. And the CDC has made a few little statements here and there that, we didn't really mean that. And actually the 90 milligram cutoff that all the states are focusing on, everybody's focusing on, doctors are focusing on, like the entire country is focused on. According to the CDC officials, it was only to be used for the first prescription of an opiate painkiller. There's nothing in there about using it, for chronic pain. But the wildfire is lit, and so it's burning brightly, and I thought I was going to start flaming out. It's not. It's getting worse every single day. There are people really who have called 20 doctors and have found none. 50% of doctors have stopped prescribing opiates. The pain clinics, a third of them don't prescribe opiates. Pain clinics, right? Don't prescribe opiates. All they do is expensive injection. There is an enormous healthcare crisis in this country, and nobody seems to recognize it.
Yeah.
And there's been plenty of people speaking up and everything. It's because they don't want to recognize it. There's too much in it for prejudice, hatred, and then $5 billion.
Stacy Fields from...
We always have to have it. Go ahead.
No. Sorry about that.
I say Americans always need to have an enemy. You know, it could be African Americans, it could be immigrants, it could be Mexican Americans, it could be during the World War I, of course. Guess what it was? Germans. You know, there's always got to be an enemy. So now people who take pain medicine, who swallow the opium, they used to call them opium swallowers, are now the enemy, and it's just awful. This is not occurring anyplace else in the world. It's a violation of all human rights. It's a violation of common decency, and it's certainly a violation of professional ethics. So,
Stacy Fields asks, are you seeing a increase in doctors giving up their DEA numbers or doctors leaving the field as a result of this crisis? She read over 3,000 have turned in their DEA numbers.
That's interesting. I've not heard that. The DEA takes about 600 a year in surrenders, but that's a statistic that's 3 or 4 years old. If 3,000 people have turned in their DEA licenses, that's much higher than the average of 600. Believe it or not, the DEA publishes every year a big document called Cases Against Doctors.
Okay, and what is that about?
And they're doing their job,
right?
And it just lists all the doctors that have been charged, okay. and most of them, well, 35 doctors a year get their licenses taken away because they're crooks.
Right.
You know, 35 people out of 1 million. But then there's 600 people that give up their licenses. I have no idea whether these people are guilty or not. But giving up your license is different than having it taken.
Right, right. I did see it came out today in articles that Dr. Forrest Tennant, you know, he's finally giving up on the fight, and he's not going to no longer see patients. By him being such a vocal physician and doctor speaking out, you know, or for at least prescribing opioids, is this to scare doctors? Will this shut things down? I mean, is that their purpose of that? Because he wasn't charged.
He was never charged, and I honestly don't know the case well enough, but I do know that the DEA took all his medical records and told him they couldn't have them back. So the patients had to go to the DEA and get their records.
Right.
You know, I know he wasn't charged.
Right.
But that's really the kind of all I know. Does it have a chilling effect on other doctors? Of course. This guy is our guru. I mean, he's the one that we go to when we're stuck, and he's the one that we send our patients to, and that's why he has so many out-of-state patients. But then they just viewed that as, oh, that must be some kind of criminal activity. You know, when I was at the Mass General, you know, there were a lot of famous people there, aside from me, of course. And, you know, people used to come from all over the world, you know, to the Mass General, you know, for specialized services. And now this is a crime that, because people go to a specialist. You know, to me, it seems like, you know, the DEA might want to appear before Congress as well and discuss, you know, what their role is and justify what they're doing. Doctors in doctors' offices who are prescribing for legal purposes, legitimate purposes is the word in the law, are now falling, you know, into DEA charges. And again, I don't know the details, but I do know that these are practicing physicians. These are not people, you know, working out of a van, or like they were in Florida, you know, working out of these pill mills, which incidentally took several years for the DEA to shut down and Florida to shut down. I have no idea why. I mean, it was so obvious; everybody knew what was going on.
Right.
So they're kind of using the same tactics. You know, they're gonna shut the supply down.
Okay. You know, the other thing I think about is when I hear like science, which science isn't 100% accurate, or if I hear stats, you know, they're not either. But I automatically consider that the truth, you know, and I think a lot of other people do. What is the correct way to set up a study and that will be used for statistic?
Well, study design, the design of a research study is where the expertise comes in. Running the study is not nearly as difficult. A lot of underlings can do that, but the real investigators, they're called, are the ones that sit down and figure out a way to be sure that the results can at least stand up to probability tests. Mm-hmm. In other words, if I want to figure out whether I need fertilizer on my lawn, I might go out there and draw a line on the lawn and put fertilizer on one half and fertilizer on the other half, no fertilizer on the other half. But then the scientist, the investigator, would say, well, wait a minute, do you get more sun on one side than the other? Mm-hmm. Are you going to have confounded variables? Is there a slope over there? It means the water's running off. Mm-hmm. And this part's going to get all soggy. This has a bunch of pine needles falling on it. It's not falling on the other side. So, and then how are we going to test this? And you test your hypothesis by assuming that it will not be different. It's called the null hypothesis. Right. And then you test it, and you subject it to common sense logic. You present the numbers themselves, let people decide, and then you use little statistical tests to try to figure out mathematically if the probability is there that this is a true difference. And so it's the design of the studies that's critical. And then you have to seal out bias. If a judge says, hey, I can preside over this trial even though the person's my nephew, I no problem, I can control the bias. Mm-hmm. Well, that's not what they do. The judges recuse themselves. They say, I can't sit on this. There's a conflict of interest. But yet the New England Journal of Medicine, that used to be considered the world's premier journal, just every week there's another drug study in there sponsored by the drug company, and always internally it's just fine, but it's always the design of the study that's key. And it's very hard to figure out when a doctor just quickly reads an article that this is a biased setup. I mean, they should not accept those studies. Right. If a drug company wants to sponsor a study, let them sponsor a study for another drug company. Right. And not their own. And then the study is done about the product they're trying to promote. It's always some expensive product, because I always look up the prices, which are never put in the study. But they're always drugs that are over $500 a month. They never do a study in there on penicillin. Right. So that's inherent bias, and you have to be very careful when you do studies that you don't let your bias sneak in, and you have to put safeguards, and sometimes you get somebody else to do the study. Right.
I just want to remind the audience, if they want to call in with any questions, they can at 415-915-2291. So what needs to happen now that the public knows that the CDC has inflated the statistics? What's going to happen with the CDC? Are they? What do you see happening? I know you mentioned that that they should go in front of the. Yeah, go ahead.
Yeah, they need to go in front of Congress, and they need to send out. See, they have email there too. Like my 10-year-old granddaughter has an email. And they can email all the doctors in the country, and they can say, you know what, let's go back and look and see what we were really doing here and what we were really recommending. Mm-hmm. Basically, the CDC took it upon themselves for the first time in 50 centuries of use of the opium from the poppy plant, took it upon themselves to say, this drug should only be used as a secondary drug. In our business in medicine, we say this is the drug of choice. If you have a strep throat, the drug of choice is penicillin. If you're allergic to penicillin, then we have another drug of choice, erythromycin. The drug of choice for pain is opium products, opiates, narcotics, painkillers. There are no other pain medicines except for Tylenol. And there's some question about whether or not it works at all, and it certainly poisons your kidney. Opiates don't poison your kidneys or your liver. As a matter of fact, they have almost no side effects. It's the perfect drug.
Yeah. Well, and I was wondering, they had to see. Go ahead.
Go ahead.
No, I was just wondering, because they had to see that. Okay. We'll try it again. Go ahead.
Go. You're the lady.
No, I want you to finish your thought on that. That's why.
CDC, you know what's missing from all the guidelines?
What is that?
What is this drug to be used for?
Right.
What's the indication, as we say in medicine?
Well,
what's the indication for opiates? Or is there any?
Is there?
Are we just not, we just going to claim that it's like no good,
right?
And it's not recommended for anybody because they might drop dead and become addicted. Well, I mean, my Lord, they're not even giving narcotics to people who are dying. I mean, how sick is this?
Well, that's what I was going to ask. Like, didn't all right? They had to know what was going to. So they put this out, and then now it's like they are picking on it and they want to take it back. Why did they not know that this was going to be? You know, did they not know that they were wanting to do this? Has this been like what is their reasoning to even put it out there if they're going to just take it back?
No, they really believed in what they were doing. They had a very small group of people who are extremists who believe that pain should just be dealt with by, you know, bucking up. And these medicines are way too dangerous to use, and there's been no study to show that they worked. Well, nobody would fund a study to show they worked because you would have to take people in severe pain, give them their pain medicine, then the other group of people in severe pain, you give them nothing. Mm-hmm. You can't conduct a study like that. That's unethical. So there never will be a study to show that. They tried up in Minneapolis with this study that Dr. Aaron Krebs produced, claiming that opiates were no better than drugstore medicines.
Right.
But she actually used such low doses that it's no wonder. And plus, you know, she picked people who probably didn't need them anyway.
Yeah, I think they said
around the country.
Yeah, they said that their worst pain was like around between the scale of the 0 to 10, a 5. I mean, those aren't the people.
A 5.
Right.
Yeah, and I did a little Twitter poll, and the majority of people who have chronic pain would be more than happy to have a 5. Mm-hmm. You know, I mean, that's the study was designed poorly. Remember, designed. Right. For example, in the group of people that use drugstore medicine, they also used tramadol. Now, tramadol technically is a non-opiate narcotic. It's still an addictive painkiller that you withdraw from. So it's like all the other ones. It's a narcotic. The narcotic's the best word. Covers everything. And they used that in the drugstore group. So the study is basically so tainted with design problems and confounds that we call, which are confounding variables. Like I mentioned with the lawn, having a pine tree fall on half your lawn is a confounding variable. It's throwing a monkey wrench into the results. So the study, you know, as far as I can see, is it's dishonest.
Right. Well, you know, I noticed that they're starting to focus on benzos now a little bit. I saw an article the other day about Neurontin in Lyrica. Now they're saying, you know, that's they're talking about the addiction level of what can happen if you take that. I guess I'm wondering, okay, so you're taking that away. You know, not every state it's legal to use medical marijuana. They're wanting to take all these alternatives possibly. So what's the answer then? Where are all these people supposed to go that have major pain diseases and health issues? What are they supposed to do? Where are they going to go? Are they wanting them to go to rehab clinics? Because I've heard of.
I think they'll leave. Yeah, I think they ought to go to Mexico. I mean, they have ethics down there. They treat in Cuba. They have ethics. They treat pain disease. All the European countries treat pain disease. Yep. This is the worst tragedy in modern American medical history.
Yeah.
And all I can think about is, thank God I don't have one of these diseases. What would I be doing? They don't give these to doctors either.
Right.
I knew a doctor. They just took him off everything. You know, and he had this horrible rare arthritis, and he was a pathologist, and he could no longer sit at his microscope. He was in so much pain. So what did he do? He quit. He quit his beloved profession, went on Social Security disability, and tried to take Tylenol, you know? I mean, this is heinous. This is heinous what people are doing.
How has the medical community reacted since since this came out, like that the CDC inflated statistics? Do you know?
Well, when the CDC statistics came out, they did a survey of doctors, and 75% of them thought it was a great idea to limit pain medicines because doctors have the same prejudice everybody else has, which goes way back to the days of the dope fiends and, reefer madness. The United States citizens and government are afraid of opiate medications. There's no other medicine that they're afraid of. And they're spending $5 billion a year going nowhere, at least in the last 100 years and 60 years since the stuff in New York City. And they're just going to keep on spending money and having commissions because they're afraid. And when people are afraid, they'll do anything. And they'll do these dumb things like they're doing in these states of limiting prescriptions to 7 days. Well, if you talk to any person with addiction disease, they'll tell you they got hooked after 3 or 4 pills. That's how addiction disease works. It triggers your brain receptors, and you get nailed. It's rare. It's only 4 people per 1,000. But, so setting up something for 7 days is just stupid. See, they're running around, do something. The sky is falling in.
Right.
And then when you get into that kind of situation, you end up usually doing the wrong thing. Right. And that's what's happened.
I know there's going to be several rallies coming up in like D.C. and they're having one I think there's a 50-state rally. People have been asking, because they're going to meet with their senators and congressmen. They want to know where they can find correct statistics to take to them when they go advocate.
Well, maybe you can organize that. You've got a website, and maybe you can get people to store things on your website in a list, and then people just click on it and print them out whatever they want. A little menu, and then they can take what they need. The basic problem is that medical care has ended for millions of people in this country who have painful diseases. Not pain, painful diseases. And what is it? You see, the next question politicians always ask, which is kind of nice, what do you want me to do?
Right.
And so there's a list of things. The DEA needs to come under control and just do their job. They picked up, 300,000 fentanyl tablets out in Utah, so that's great. That's what they need to keep doing. Do they need to be raiding doctors' offices with guns and flak jackets? What are the rules of evidence? Blah, blah, blah. CDC needs to do a real mea culpa. CDC needs to tell doctors that here's what you can do with these drugs. Here are the types of, and we're sorry about this 90 milligram thing you misunderstood, but we never said that it was for chronic disease. And they need to make that clear. And they have a nice way to do that. They publish a little pamphlet every single week called Morbidity and Mortality Weekly. That's how the CDC regulations got published in their little weekly newsletter to the world.
Really?
And so they could put a little article in there in MMRW or WR or whatever, their little weekly publication, and put an article in there written by the CDC staff saying, whoa, we did not really want this to happen. And here is where we made mistakes. And here is our real recommendation. And we understand that we're not the agency really in charge of this. So take these lightly. These are just ideas that we have as epidemiologists. And here's what we thought we could do. And you know what? 2 years later, we did the wrong thing. Now, you think they're actually going to do that? I don't know. But that's what they should do if they want to be grown-ups.
Right. The thing that, I think we get lost sometimes, and because there's just so much information out, and it seems like everything keeps changing, and something comes up. So the government is so concerned about overdoses and addiction. What do they need to do to change these problems? Like, obviously, writing fewer or no prescriptions for pain medicine, it's not helping. And I mean, and now they're wanting to cut even a third more on that. So if they really care about the overdose and the addiction part, what needs to be done to change that?
Well, they need to hear from people with severe pain disease, and they should commission studies. The CDC was required by its scientific advisors to provide follow-up studies to be sure there were no adverse consequences. Mm-hmm. Well, guess what? There are adverse consequences, and it's much, much bigger than the opioid epidemic. Much bigger. There's 1 million addicts in the United States, addicted people. It's not increasing. The overdose deaths are 33,000 a year, which is awful. But there's 5 million people being actively having their pain medicines taken from them by force. So, I mean, if they don't have the ethics to understand what pain is, then we need to get a big law firm involved.
Yeah.
And we need to put up an injunction to stop this until there's evidence that they are correct. And I'm afraid after 6 to 8 months of review and all this, and looking at these papers and looking at their viewpoint, they do not have a leg to stand on.
Yeah.
What they're doing is immoral, and it's just plain wrong.
Well, and I always wonder too. I mean, why aren't they just simplifying all of this? You know, I mean, they're making it so difficult.
They're the government.
Yeah, exactly right.
They're the government. You know, I mean, you know, they got a lot of jobs to protect, and they need funding next year, and you know, it's the typical part of the government. When does the government change? I'll give you an example. The Internal Revenue Service used to be like the Gestapo, you know, 20 years ago, 25 years ago. They had their own police force with guns, and they used to terrorize people. And they terrorized some poor priest up in Minnesota somewhere. And so they had a congressional hearing, and he came and testified, and several other people testified about what the IRS police were doing. And Congress was so alarmed. And they said, we didn't know this. So you got to tell Congress. You got to speak up. They said, we didn't know this was going on in the IRS. Thank you for coming. And they passed several laws quieting the IRS down and taking a lot of their police powers away from them. And now when you call the IRS, I had to do that several years ago and say, look, I made a mistake. Oh, no problem. What can we do to help you? You know? So the same thing needs to occur with the CDC. And the FDA needs to step forward and say, look, we're the regulatory agency. You are not. I hope the FDA doesn't change its mind, but right now it's legal for me to prescribe any FDA-approved opiate in the country, anywhere in the country, to a dose that I feel is necessary for the patient. It's an odd group of drugs. With no upper limit. That makes it different than most of all our other drugs. But still, that's the way the FDA set it up. And so I can still legally prescribe any dose that works for a patient.
Next year in 2019, Medicare and Medicaid are putting through that, I believe it is that you're not going to be able to prescribe over the 90 MME limit. And that's, you know, a blanket thing for the whole United States. What do you think about that? I mean, so if you're prescribing in your state, then do you have to stay below that law-wise?
Well, I would if I was seeing Medicare patients, but they're not gonna put that through. Not after reading my comments I left on the website.
Really? It won't, because
they were good. Let me tell you.
Well, okay, no, because I've had a lot of people ask.
If Medicare wants to do that, they need to go to the FDA. They're not the regulatory agency. They can't set limits, prescription limits. What are they doing?
Okay, so that's not true. Then.
I mean, it may take some lawsuits and stuff.
Yeah.
Well, they're trying to do it, but you know, I think when they sit around the table and go, "Uh-oh,
yeah,
we don't have the authority to do this." The states don't have authority either. Only the FDA. Now the FDA is trying to put some limits on there too, and if it does, I'm moving to Mexico.
Yeah. Yeah, me too.
Where they still care about people.
Who would ever think, you know? What do you think about governors? Because all right, if you go to your governor and they decide to do a state of an emergency, is that a possible thing? What do you think?
To do it in reverse, yeah.
Yeah.
In other words, have a state of emergency for not the 20 or 30 or 40 people that died last year, but in North Carolina, there's about 200,000 people who are being yanked off their medicines against their will.
Mm-hmm.
You know, so yeah. You know, I found out, I didn't realize why they did that with the state of emergency. They don't have to hold public hearings.
Right.
So you see, they just get to do whatever the governor wants to do. You know, you can just be an El Duce, you know, and say, oh, okay, here's what we're going to do, and I'll get a lot of votes for that. And I got a lot of people complaining, you know, and sadly it's from a small number of voters, you know, who've lost their kids through ignorance. I'm sorry, it's ignorance. It's just like the days of not teaching sex education, and then all of a sudden somebody gets AIDS, you know?
Mm-hmm.
It's the same thing. There's no reason for a teenager to die if there's proper education in the schools about what addiction disease really is.
Yeah. Yeah. Well, Dr. Kline, we're going to get going here, but was there anything else that you wanted to talk about before we did, and any more comments on CDC?
No. Can I talk about my jellies and jams that I sell?
Sure. I'll buy some. How much are they? What kind?
Well, I have them in the trunk of my car, and it's sort of black market because they're very special because they've been restricting these jellies and jams in stores.
Uh-huh.
So.
Alrighty. Well, thank you so much for coming on. Me. Yeah, I hope you have a great night, and we'll see you next Tuesday. Thank you. And Carnation, bye-bye. Carnation, thank you so much for coming on this evening. Don't forget, tomorrow at 8, 7 Central, we're going to have guest Dr. Edward Spencer joining us to discuss about losing his physician's license to treat patients, all because he spoke up publicly about vaccinations. And we'll discuss also the links and similarities of the health epidemics throughout history within the United States. So I hope you have a great night. Please join us tomorrow, and we'll see you then.
You've been listening to The Doctor's Corner with Dr. Kline and Janelle Elgway. Copyright 2018 by EXG LLC. All rights reserved.